So good morning, everyone. Welcome to India-US Summit, Day 3. That is the last day. And this is still mid-afternoon. And the present session, the chairpersons are Dr. Roy Mukuda, Dr. G.S. Lamba, Dr. Nikhil Mahajan, and Dr. Siddharth Srivastava. In this session, we have an eminent speaker, Dr. Bin Moller, Dr. Anthony Theo, Dr. Ishiyama, Dr. Surinder Rana, and Dr. Vipul Rathod, who is a father of EUS in India. So I request chairperson to start the session, and is a request to the speaker to stuck to the time. In the last 2 days, we were able to maintain. We have entire program is delayed only by 10 minutes. And the last day also we should not delay and we should finish on time. Thank you. And we start the proceeding, hand over to chairperson. Thank you.
Yeah.
Hi.
Good morning, everybody. First of all, I'd like to congratulate Rajesh for holding this wonderful conference. These 2 days have been really very exciting, and we've had some very good lectures and demonstrations. Now one good thing which Rajesh has done, if I have to give an analogy to cricket, is that he's kept his best batsmen for the slog overs. So in the last day, we have some of the very eminent speakers for this very exciting session. And thanks, Rajesh, for organizing it this way. So we start this session with a very exciting innovation or extension of EUS, that is EUS guided vascular therapy. And we have with us none other than Dr. Kenneth Bin Moller, who's going to talk about this very exciting field, extension of EUS therapeutics, that is EUS guided vascular therapy. Over to Dr. Bin Moller.
Greetings from San Francisco. FNA is, of course, a routine part of our daily practice, but increasingly we are applying FNI. We can inject, we can implant devices through the same needle that we use to perform FNA. We can inject a sclerosant, we can inject cyanoacrylate glue, we can implant a coil, and there are a growing list of injectates and implants that we can introduce under EUS guidance. Now the question is, what is the added value of targeting a vessel under EUS guidance? Well, as endoscenographers, we like to see the whole picture. We want to see the vessel lumen as well as the feeder vessel. And we want to ensure that our delivery is intravascular so that we have indeed targeted the vessel. We also have the advantage of Doppler flow that allows us to confirm treatment success. But an important practical advantage is that we are not dependent on endoscopic visualization. EUS always complements endoscopy, but we have the option of performing treatment without endoscopic guidance, and this is beautifully illustrated in this video here. There's active bleeding from this gastric varix, and the endoscopic view reads out within seconds. This is where we can switch to EUS and proceed with EUS guided treatment. With EUS, we can target the feeder vessel. This is nicely illustrated in this case of a patient with a refractory Dieulafoy bleed. The Dieulafoy lesion is a feeder arteriole, and you can see this arteriole traversing the wall of the stomach. You can see the Doppler flow, and we can now target that vessel with a FNA needle, using the needle to inject cyanoacrylate glue directly into the vessel lumen, and we see the glue, which is echogenic, disperse within the arterial lumen. And within just seconds, the lumen occludes and the Doppler is negative, confirming that we have obliterated the lumen. Similarly, in this patient with an esophageal varix bleed, who had undergone multiple band ligation, so a refractory bleed, we see yet again a bleeding varix. We can, of course, band this once more, or we can switch on the Doppler and we see the perforator, varix, and the extramural collaterals. We are targeting that perforator or penetrating vessel, and just as you saw before, injecting the glue directly into the perforator. The bleeding has now stopped, and you can see the glue extruding from the puncture site. This concept of targeting the feeder vessel was in fact introduced some 15 years ago by a group in Brazil. They randomized patients to endoscopic sclerotherapy versus EUS-guided sclerotherapy of the feeder vessel. 50 patients randomized with 6-month follow-up. The feeder or the collaterals targeted. The EUS group had fewer and later recurrences. You see this nicely in the graph here. These are the patients who underwent EUS-guided targeting of the feeder vessel. The study showed that the reason for the higher rebleeding rate in those patients undergoing conventional sclerotherapy was due to persistent collateral vessels. That resulted in a higher rebleeding rate, and this was statistically significant. Carrying now this concept of targeting the feeder vessel to gastric varices, it was Dr. Romero Castro who first reported the injection of glue, cyanoacrylate glue, targeting the perforating feeder vessel. He reported this as a proof of concept in 5 cases and used histocurl diluted with Lipiodol, with excellent results in this proof of concept study. But what's important to note is why he performed this targeting of the feeder vessel. It was to minimize the amount of glue that needed to be injected to obliterate the gastric varices. Now, the rationale for targeting the feeder vessel is not only to potentially improve the outcomes of the glue injection, but more importantly, to minimize the risk of the most dreaded complication of glue injection, which is systemic embolization or migration. The glue can embolize anywhere in the body, the lungs, portal vein, spleen, even the brain if the patient has AV shunts or an open foraminovalle. Here, the kidney. Here you can see the glue actually inside of the renal vein. This study nicely summarizes what has been reported in the literature, which is no doubt an underestimate, but we have 27 reports of systemic embolization or migration with 11 organ infarctions and 7 deaths. So this is a humbling complication of glue injection. So what about just eliminating the glue and replacing it with coils, which of course are commonly used by our radiology colleagues? Dr. Romero Castro also reported this for the first time in a proof of concept study in 2010 for patients targeting, again, the feeder vessel, the perforator vein, with eradication in 75%. But he had to use a large number of coils to accomplish this, a mean of 9 and up to 22 in one patient. What followed was a very, I think, illustrative study that compared historically the results of EUS-guided coil treatment versus EUS-guided glue injection. And this is a multi-center trial from Europe, total of 30 patients, 6 centers. But again, retrospective, non-randomized. EUS-guided glue was used in 2/3 of the patients and coil alone in the other 1/3. They obtained CT scans in all patients after the treatment. And they found that in the patients undergoing glue injection, lung emboli were found in nearly half of the patients, 47% on CT scan. Fortunately, these patients were asymptomatic. When they looked at the patients who underwent coil injection alone, there was no evidence for coil embolization. In 18% of the patients who underwent coil treatment alone, they still needed glue injection. And yet none of these patients had glue embolization on their CT scan. And it raises the question whether the coil may in fact prevent the embolization of the glue. The coil alone fills and reduces flow in the varix, but the wool strands serve as a scaffold to retain the glue at the site of injection. In this ex vivo model, after deploying a coil followed by glue into a container of heparinized blood, you can see that the glue is adherent to the woolly strands of the coil. This is nicely illustrated in this patient with a humongous gastric varix or convolute of varices. We can see the 19 gauge needle puncture the varix, and we deploy the coil, which is echogenic, into the varix lumen. It unravels. You can place multiple coils depending on the size of the varices. This is followed by the glue injection, which then adheres to the coil. And this is the appearance 9 months later, showing the varices obliterated. And on EUS, no residual varices were seen. We reported our long-term results in a large cohort of patients, 152 patients, treated over a 6-year period with a mean follow-up of 1.5 years. And our rebleeding rate was 8% from gastric varices, overall 16%. And we had one patient who did develop a pulmonary embolus, but this was 1 week after the patient was discharged from the hospital. So it's not really certain that this was a glue embolization, but of course, we counted that as an adverse event. We're now seeing data emerge comparing EUS-guided coil and glue versus conventional treatment. This is one study from Brazil. It's what I would call a pilot randomized controlled trial because only 32 patients were randomized in this study. Good results in terms of the obliteration of the varices. The patients who underwent coil and glue had a 25% rate of lung embolization by CT scan versus 50%. This did not reach statistical significance, but then this is also a small study, so this could be a type 2 error. Now, the only issue I have with a study like this, though, apart from the small size, is that we're comparing apples and oranges. Really, we should be comparing EUS-guided coil and glue versus EUS-guided glue alone. We know now from this randomized controlled trial that the results of EUS-guided glue treatment are superior to conventional endoscopy-guided glue therapy. EUS was superior in this randomized controlled trial of 40 patients, resulting in less glue required to achieve obliteration, a lower rate of gastrovaricial rebleeding, and a lower rate of non-gastrovaricial rebleeding. If we look at EUS-guided treatments alone, we have glue alone versus coil alone versus the hybrid glue plus coil. Coil and glue was superior in reducing the recurrence of gastric varices. So this was statistically significant. Also, we had a significantly lower rate of late rebleeding undergoing the hybrid approach. And the latest study from last year compared EUS-guided hybrid approach, coil and glue, with just coils alone. And this study showed in all of these categories, rebleeding, varix reappearance, reintervention, free time, and reintervention number, significantly better results. Few words about EUS-guided portal angiotherapy. The advantage of EUS-guided treatment is that we have direct access to the portal vein. And there are two applications. EPIC has only been evaluated in animal studies so far, but the concept is very sound and makes great sense. The goal is to optimize liver levels of chemotherapy while minimizing systemic levels of toxicity. EOS-guided TIPS has conceptual advantages. It is ultrasound guided versus fluoroscopic. And as mentioned, we have direct access to the liver vessels from the stomach. And we can combine it with other endoscopic treatments such as glue, coil, or both. And here are just some images showing some of the early animal work that I was involved in. So in summary, current status, we are using EOS-guided vascular therapy for refractory bleeding when endoscopic treatment fails. For fundal varices, EOS-guided treatment has been found in randomized controlled trials to be superior to endoscopy-guided. I think this should become, where available, the new standard of care. And coil and glue appears to be superior to glue alone, but we do need randomized controlled trials in the future to further investigational applications, infusion portal vein thrombolysis for portal vein thrombosis, and then coil embolization to induce liver lobe hypertrophy. Thank you very much for the opportunity to contribute.
Excellent overview of how we can use this EUS for vascular innovations. I think in the future, we are going to have much more vascular interventions with the EUS. Dr. Rajesh, do we have question answers now? Or?
Yeah, in the same session. We have 4 minutes to ask Dr. Binmoller. 4 minutes are there to ask the questions.
So if we have any questions for Dr. Binmoller, we can invite them.
Can I ask one question to Dr. Binmoller?
Yeah, sure.
In my opinion, the vascular therapy has not gone from bench to bedside yet. Why? What could
Great
be the
question.
cause?
Well, first of all, I think it's a mindset issue. Remember, when we learned endosonography, we were taught to avoid vessels. So that was the enemy. So now we're actually targeting a vessel intentionally for therapy. So it takes a change in mindset to actually target the vessel for treatment. The other reason I think is historic, but is rapidly evolving, which is simply there were a limited number of endoscopists trained to use EUS and performing interventional therapeutic procedures. But that is dramatically changed over the last, let's say, 5 years now, where we're draining pseudocysts, we're draining the gallbladder, we're doing gastroenterostomies. So there's a whole array of therapeutic procedures that have now become increasingly mainstream. So that's why I think we're also going to see the addition of these vascular treatments. So this is something that we're going to be hearing a lot more of in the future.
So Dr. Binmoller, I think I've done more than 50 fundal varicose glue, coil and the glue injection with an EUS. My feeling is still the endosonographer is not taking the way the biliary drainage has come up, the way the pancreatic fluid collection has come up. Still the people has not, endosonographer has not gone to develop the vascular therapy with their intention that we can propagate this. This is my thought process. And that's why it has not come to the bedside. This is our duty, I think. Those who are doing endosono, they should propagate more for it. We should make more guidelines, and that help the understanding of the gastroenterologist that they can use this modality more and more.
You know, just to make a comment about how new technology disseminates. So of course, education is colleague to colleague, education is very important. But this is where I also feel that our partnership with industry has great value. And one of the reasons why I pushed forward with Axios, with Xlumina, was because in the early days, industry wouldn't listen to my pleas to please develop tools dedicated for EUS guided therapy. If you think about it, the problem with glue and coil is that right now we don't have industry endorsing or promoting its dissemination in our space. Radiologists use this, but it's not being used in our space because it's off-label. And so perhaps if we can incentivize or motivate industry to also invest in these platforms to make it more user-friendly, we'll see greater dissemination.
And one last question from my side, and it is a personal problem which I face with the patient. And because you are innovator, you can give idea. The young patient from Germany, he has portal vein thrombosis, he has superior mesenteric vein thrombosis, completely occluded. And he has a carpeting of the duodenal varices, right from the D3 to DJ flexion.
Yes.
I did the EUS guided coil and glue. It is not one, it is a carpeting, like a longitudinal carpeting of the vessel. There is no big single varix.
Yes.
I did EUS guided coil and glue 2 times. Every time he flew from Germany, and third time he has a bleed in his own country, it was not possible. Surgeons was not able to do it because SMV in the portal vein was thrombosed, and IR people was not able to do it. Now the issue is we have only limitation of doing EUS guided. What else we can offer, because he's only 35, 37, and EUS, on EUS also he has bled twice.
Yeah.
What is the best option for this patient?
Sadly, these are the most challenging, are the duodenal. And the main problem with the duodenal is now the risk of embolization of the glue into the portal vein and to the liver is significant. So that's the first thing. The second is you're in a much more constrained space. The varices are more narrow caliber, and it's much more challenging to identify the feeder vessel. But using a 22 gauge needle, perhaps you could consider, and I've done this in these cases in the stomach at least, with many ropey, small caliber vessels in patients with rebleeding, where I've just targeted multiple vessels, placed the small coil, then the glue, and I did that at multiple sites. I think that's the best we can offer for a situation like this. This is clearly the most challenging. And I think you need to always have the disclaimer that duodenal varices are not gastric varices. It's a different animal. So we can't expect the same results.
I have used gel foam and coil in duodenal varix, which I thought is a good, because the side effects, I feel that it's better than glue in duodenal varix. Only problem is gel foam. The next in this EUS, the coil was there, but nothing else. It was completely thrombosed. So I don't know, what's your experience with gel foam use? I've used it in the fundal varix also.
Yes, gel foam, of course, it's well established. It's used by our radiologists all the time. The issue with the gel foam, though, is that it will embolize very readily. So it doesn't have any adherent properties. See, cyanoacrylate does adhere to tissue. Gel foam will not adhere. So now your risk of embolization is especially high. So it works in a procedure like Berto, with balloon retrograde occlusion, where the balloon is preventing embolization. So if you use gel foam, then you absolutely must pack with coils, and really under fluoroscopy, you should confirm that there's really minimal to no residual flow. Then it begs the question, what is the gel foam really adding to the coil? So the problem with gel foam is, number one, not adherent. It will readily embolize, and it's biologic in the sense that it will degrade, unlike cyanoacrylate, which is permanent.
One question from the audience, Dr. Binmola. Dr. Sandeep Javan wants to know, what is your experience with thrombin injection in gastric varices?
It's the same. We used it in Hamburg very early on when I joined the group in Hamburg. And the results look great initially, but these patients have a high later rebleeding rate. So not early, but late rebleeding. And again, it's because it's biologic and the thrombus then degrades. And when it does, these varices open up. So remember, we're not treating the underlying cause of the varices. The pressures are still very, very high. So unless things really scar down, and they do with cyanoacrylate, that's why it's time proven, it scars down. You know, the glue, it emits formaldehyde, and this formaldehyde is actually quite caustic, and it creates a severe scarring reaction. This is why it's so important to inject the glue into the varix and not outside the varix. That's why US guidance for glue injection, I think, is really the right way to do this, not endoscopy guided, because you can be fooled thinking you're in the varix lumen, but you're actually outside.
To be on time, I would request if we can move on to the next
Okay.
topic.
Thanks, Dr. Minimolo. That was an excellent talk, I think, and this
Thank
is a
you.
very exciting field, and I think it's going to pick up in the future, definitely. Dr. Roy, can you invite the next speaker, please?
Yeah, I think next is Anthony Thieu. I don't think he requires any introduction. Please start on. I think we'll not waste time. Please, Anthony, welcome.
Good morning, everyone. So thank you very much for having me here to share some thoughts, and it's good to see you all. Hi, Ken. How are you? I'm going to be talking about something not so often we talk about, because you're always worried to share our complications. But I think these experiences are important because we need to learn from our mistakes. And I always think it's better to learn from other people's mistakes and not go through your own. Oops. Presenter view. Sorry, do that again. Are you seeing the presenter view, or is it okay?
We can see you.
Yeah.
So should you guys want to see this instead? Is this better?
Full slide.
We can see the title slide, yeah.
Right. So I should use this, right? Okay. So anyway, so nightmares in US interventions. So a long time ago, when I first started learning US, one of my teachers used to tell me, when you succeed, you become a hero in these US procedures, because you accomplish the impossible. The procedure has been failed by many people before you, and you were able to complete the procedure with the US guided intervention. But one problem with US interventions is a lot of times it is a one-shot procedure, meaning if you miss something, if you made the slightest mistake, you really fail, and you could fail miserably. When you manage complications in intervention in the US, so what you originally tried to accomplish now becomes two problems to deal with. So you really have to ask yourself a number of questions. Firstly, whether you can deal with the problem yourself. Should you continue with the procedure, or should you go to plan B, which commonly involves radiology or surgical colleagues? Can the patient tolerate a longer procedure, or even tolerate another failure when you try to salvage the procedure? Is there someone in the center who could do a better job in the unit? If so, maybe you should ask for help. And also whether you need to involve the surgeons or radiologists in a very early manner, because you wouldn't want to wake someone up in the middle of the night and trying to ask them to come and help you. So in terms of potential complications, I've identified a number of potential things that might happen, mishaps during these US interventions, including stent misdeployment, migration, blockade, perforation, foot impaction, and bleeding. So for me, the top 5, we can usually salvage with endoscopic intervention. But with bleeding, sometimes we will also need IR or surgical colleagues to help.
Sir, can you please request for the presenter view, because the slides are not being projected outside well.
All right. Is this better?
Yeah, that's right.
Yes.
Okay, so I'll start talking about the first complication first, malposition or migration. And this is one of my favorite procedures, EUS guided gallbladder drainage. This was a very early procedure, maybe almost 8 years ago. The third case in the first 10 cases in Prince of Wales. So at that time, we were still using the cold axials. So we had to puncture, dilate with a cystotome, followed by tract dilatation, and then stent insertion. And at that time, we were still using the old technique of visualizing the black marker before opening the proximal flange. So as you can see in this video, the gallbladder is inside, the distal flange is opened. I pull back the gallbladder flange. And at this juncture, I usually switch to endoscopic view to see the black mark. Now you can see my stent moving slightly forward. I wasn't sure what was happening. And I changed back to endoscopic view. And I should see the black mark here, which is there. So now I'm happy. I deploy my proximal flange, but nothing happened. So I remained still. I checked again. I saw my handle is completely opened, but the black mark is still here. So usually we would see the stent by then. So I wasn't particularly sure what's happening. But having already deployed the stent, I just pulled back the delivery system, and the stent wasn't there. You can see a hole right there. So luckily, I have a guide wire in place. And I noted I've actually deployed the entire axials in the gallbladder. So luckily, I have a guide wire in place. So I was able to use this wire to salvage this. So I inserted another axials, but you can also use a straight metal stent. And then pushing inside. So this was a stent in stent manner. Deploy the distal flange and then pull back. And this time, now deployment of the proximal flange was much smoother. So I was able to salvage a misdeployed stent because my guide wire was still in situ. So what happened? So now I know what happened. So because there are several knobs in the handle of the axial stent. So before you deploy the distal flange, the proximal flange, you have to lock your first button. Because if you don't lock it, you would deploy the entire stent into your target organ. So this is why what happened when I was deploying my proximal flange. So this is the X-ray. So it looked okay. So we were able to salvage this. So lesson to learn: if you are not familiar with procedure, the guide wire is very important. So if there's any deployment, stent malpositioning, the guide wire can allow you to have a second attempt, and usually the patient won't suffer from any significant consequences. Perforation, another gallbladder case. It all went very smoothly. So this was actually done by my trainee. This is the gallbladder, direct puncture, deploying the stent, pull back the stent. So everything was smooth. So the stent was even deployed here. But I have this tendency, so you can see the stent right there. I have this thing that I always do is I try to visualize the stent opening and suck out as much bile as possible. But this stent, after deploying, it tends to be facing downwards. So I have to push in the scope and try to torque right in order to see the lumen of the opening of the stent. And this is what happened when I was doing that procedure. So be very attentive. I turn, And I try to turn again. You see all that? This is extraluminal fat. So I wasn't sure what happened, but I was doing a torque movement and suddenly there's extraluminal fat. So I panic, I pull back my scope, change to a regular gastroscope. I saw a lot of bleeding. So there's bleeding right there. And there's a hole right here. Right there. And it's just next to the stent. Here is the stent, just next to the stent. So what happened was I was trying to torque my scope. Okay, contrast here, extravasation. I was trying to torque my scope to see the lumen, but instead I went between the stent and the GI wall. So this is something new to me. I tried to clip it with several clips and praying that this would seal well around the stent. So 2 or 3 clips and then all the way to the stent, axial stent. So after I think around 3 clips, it looked okay. 3 or 4 clips. So injection of contrast. Now I'm feeling better because no more leak. So lesson number 2, all these are newly created anastomosis. So don't do too many manipulations because you will run into problems. You might dislodge the stent. You might cause a perforation like what I did just now. And whenever you do these manipulations, be very, very, very gentle. Okay, this is an interesting bleeding case. It's actually a case from Dr. Itoi. This procedure is a difficult procedure. It's a difficult HGS. Patient had a C rectum, laparoscopic Hartmann's operation done, liver metastasis, right hepatectomy, now has a left obstructed duct. And left PTBD was performed and they planned for internal drainage. So of course there are several options. You can try to internalize from a PTBD. You can re-operation, re-anastomosis, and or perform the HGS. So this is the cholangiogram from PTBD. So straight away, you know this is going to be a difficult one because the ducts are super non-dilated. Even for internalization, it seems to be a very tight stricture right there. But anyhow, knowing Dr. Itoi, anything is possible. So first, they injected some contrast through the percutaneous drain and then changed to EOS. It's very, very small ducts. So he was moving around. All of these tubular structures are mostly vessels. Changing the scope position according to X-ray. And then using the PTBD right there. It is also a landmark. But we can see the duct right here. It seems to be a sizable caliber, but in front, there is a vein, hepatic vein, or portal vein. So I think he attempted to go around it with the needle. The needle's coming in right there. But seems like the vein is right in front of the duct. So another attempt. Okay, now the needle is in the duct. Seems like it. It's very deep. But also looks like it's traversing the vein as well. Hard to say. So anyhow, since he think he was in the duct, so he tried to inject some contrast and pass a guide wire down. So this is the wire via the percutaneous drain, and then the wire EOS. Okay, so both wires are in the duct. So now we need to make a decision. Should we proceed to dilate the track, or should we pull everything out? If you pull everything out, there might not be a chance to be able to complete this EOS-XGS. So being Itoi Sensei, I think he decided to proceed. So we do the usual things, dilation with the 6-French cystotome, and then stent insertion. But now, you are starting to see all these moving fluid around the liver. It's quite active and becoming bigger and bigger. So definitely there was the vein that was punctured just now, definitely was punctured. And with the big hole after dilatation, there's obvious bleeding. So what can we do now? So I think the idea is to trying to complete the procedure, and hopefully a metal stent can compress on the bleeding vessel and be able to stop the bleeding completely. It may work, it may not work. I think it tends to work better with veins. With arteries, it may or may not work. We had an experience with an artery puncture that required our intervention. Anyhow, the stent was deployed. This is just my last slide, so I'll be done after this video. Okay, so the stent is deployed. EOS seems like the bleeding has stopped, so everybody is happy. Okay, this is the post-op appearance. The patient had a small collection after procedure, but he or she did well. So tips and tricks. Most importantly is that you need to have good planning. Always important is to select your site of puncture. Always have a plan B if plan A doesn't work. There's no room for error. You need to have very good preparations, trained staff, adequate accessories, and look for backup. So in conclusion, complications in interventional EOS can be terrifying. Make slow, cautious steps in learning EOS. Be friends with radiologists and surgeons. Initial learning is best in presence of experienced endosonographers. But there is definitely great rewards in successful cases. So thank you for your attention.
Great talk, Anthony. That was really good. One question, how could we have prevented that perforation you showed?
Yeah, I for that complication, I feel really stupid because the whole procedure was already done. And I was trying to do something additional. I was trying to turn my scope, and because the stent was angulated away, so I had to turn my scope and try to push it so that I can see it from end on. So for that case, the best strategy is not to do anything too aggressive, because yeah, the stent itself, it should be able to drain all of the dirty material from the gallbladder.
So we can, I think, go for the next talk.
Yeah.
Thank you.
Thank you.
Thank you.
I would request the chairpersons to invite the next speaker, please.
Okay. Good morning, everyone. I think next talk is by Dr. Rana, Dr. Surinder Rana, about how to do a liver biopsy. Is Dr. Rana there? Yeah. Hey, good
Yes, Siddharth, good morning.
So,
good morning, everyone.
Morning.
Please go ahead with the lecture.
Yeah, right. Thank you. Thank you so much. Good morning, everyone. At the outset, I would like to thank Dr. Rajesh Puri and the organizing committee for inviting me and giving me an opportunity to participate in this great EOS academic program. Today, I have been asked to speak on the role of EUS-guided liver biopsy. We all know that laboratory and imaging modalities can help in diagnosing various liver diseases. And with the advent of non-invasive markers for liver fibrosis, the need for liver biopsy is gradually decreasing. However, still the histology remains the gold standard for diagnosing as well as prognosticating various diffuse liver parenchymal diseases. Liver biopsy still plays a pivotal role in evaluating and directing therapeutic management in various diffuse liver diseases. And a study has shown that liver biopsy actually alters the therapeutic management in 18% of patients with diffuse liver diseases. Therefore, the liver biopsy is going to remain in clinical practice. Now, the liver biopsy can be obtained either percutaneously. Initially, it was used to be done blindly. With the advent of ultrasound, it is now being done image-guided percutaneously. Then even it can be done transjugularly. And one can do a liver biopsy through a surgical route, which can be either an open or a laparoscopic. And now we have an EUS-guided liver biopsy in which EUS can be used to obtain the liver biopsy. Before we go on to the techniques of EUS-guided liver biopsy, it is important to know what is a good quality liver biopsy. We know that the length as well as the diameter of the biopsy core affects both the grading as well as staging of the liver biopsy. And studies have shown that at least 11 or more complete portal triads are needed to overcome the inter-observer variability as well as the disease heterogeneity. And complete portal triads means a complete circumference with all the three portal structures within it, which include the branches of the hepatic artery, portal vein, and the bile duct. And studies have shown that a liver biopsy, which is at least 2 centimeters long and 1.4 millimeter wide, with minimal or no tissue fragmentation, will guarantee these 11 complete portal triads in almost 94% of patients. Therefore, a good liver biopsy should have at least 11 complete portal triads. Now, a percutaneous liver biopsy is the one which is commonly performed. It is easily available across, and studies have shown it to be cheaper and a cost-effective way to obtain a liver biopsy. Now, why should we do an EUS-guided liver biopsy? EUS-guided liver biopsy can be practiced in clinical practice if it has got complications which are equal or less than the percutaneous liver biopsy, and also the adequacy of sample should be as good or better than a percutaneous liver biopsy. And also, more importantly, if EUS-guided liver biopsy can provide us some more added information, then obviously it will score over a percutaneous liver biopsy. Now, this idea of using EUS to perform a liver biopsy has a number of appealing aspects. First, both lobes of the liver can be sampled in one procedure. And moreover, in EUS, we use Doppler, so it reduces the risk for vascular injury as well as any bleeding. The procedure can be done simultaneously with therapeutic endoscopy and same sedation on a same table in patients with cirrhosis. And it is less painful than a percutaneous liver biopsy as you don't pierce the skin. And also with the advent of EUS-guided portal pressure measurement gauge, and additional information can be obtained while performing an EUS-guided liver biopsy. Now, how to do an EUS-guided liver biopsy? Basically, in EUS-guided liver biopsy, the whole liver cannot be sampled. Segment 2, 3, 4, and 5 of the liver, which are adjacent to the stomach and duodenum, can be sampled using an EUS-guided approach. Now, what you do is, first you access the right lobe, which is segment 4 and 5. You take an EUS scope to the apex of duodenal bulb. It will be downward facing. So you do a 180-degree clockwise torque so that it starts facing cranially, sees the undersurface of the liver, make a knob up so that the transducer comes closer to the liver surface, and then using a Doppler, you identify any avascular plane through which you puncture the liver to obtain a liver biopsy. For a left lobe axis, you just go across the GE junction, identify the celiac artery, do an anti-clockwise torque, identify the segment 3, do a knob up, and then do a liver biopsy. Just to show you how to approach the right lobe, go into the duodenal bulb. The scope is facing downwards, do a 180-degree torque upwards, you see the undersurface of segment 4 and 5, avoid the gallbladder, and do a puncture to obtain a liver biopsy. So this is how you do for the left lobe. You identify the IVC, do an anti-clockwise talk, you will identify the liver hilum, and further anti-clockwise talk, you will have the left lobe of liver, which can be approached. And similarly for the right lobe, you go to the duodenal bulb, do a clockwise talk to the undersurface of liver, identify the segment 4 and 5, and then sample the right lobe. So same thing being shown on fluoroscopy. For the right lobe, you have to be in the duodenal bulb, and from the left lobe, you have to be just across the GE junction, approaching the segment 3. So this is what you do once you identify the site of puncture. This is the left lobe liver biopsy. Use a Doppler to identify an avascular plane, and then using a 19 gauge or a 22 gauge FNB needle, the tissue biopsy is obtained. And this is what you get. You tissue core, put it on slides, and from here you pick it up. The cores are put in a formalin vial and sent for histopathological evaluation. Now we have learned about how to do an EUS guided liver biopsy. The next question arises is, we have so many needles which are now available, which needle to use for obtaining an EUS guided liver biopsy? These are the studies which have been done with various commercially available 19 gauge needles. These all are FNA needles, and this is one a biopsy needle. And all these studies have shown that the diagnostic adequacy is well beyond 80% in all patients who have undergone an EUS guided liver biopsy. This is a very interesting study which compared the EUS guided liver biopsy with percutaneous and transjugular liver biopsy. This study showed that once we compared a both lobe, that is right and left lobe EUS guided liver biopsy with percutaneous and transjugular liver biopsy, the total specimen length as well as the complete portal triads were significantly better with EUS guided liver biopsy as compared to percutaneous and transjugular liver biopsy. However, if only one lobe was sampled, then the diagnostic yield, the complete portal triad number, and the total specimen length was comparable across the 3 intervention arms. And also, if we look at the longest length of the piece which has been obtained, the length of the longest piece was much better with percutaneous and transjugular as compared to the EUS guided, even both low liver biopsy, thereby suggesting that fragmentation is a disadvantage of an EUS guided liver biopsy. However, this study was done using a 22 gauge needle, and thereafter this study was done with a 19 gauge FNB needle. That's a shark port, which is a fork tip needle. In this, a slow pull technique was used to obtain the tissue core. And in 24 consecutive patients who underwent an EUS guided liver biopsy, the median number of passes required was 2. However, look at the median tissue length as well as the median complete portal triads. It was 32.5 and more than 6 centimeter respectively. This suggests that you are having the length as well as number of portal triads much beyond what is needed for an adequate sample. And therefore, the histological diagnosis was achieved in almost 96% of patients in this study. Now, once we have learned that a 19 gauge needle is giving us a better sample, these retrospective studies have confirmed it. Now, the next logical step was to perform a prospective study comparing a 22 gauge needle with a 19 gauge needle. And this is an interesting prospective study comparing a 19 gauge aspiration needle with a 22 gauge core needle, which is a shark core needle. This study found that with 22 gauge needle specimens were significantly highly fragmented as compared to 19 G cores. And this study also showed that the tissue fragmentation occurred during the histological processing and tissue embedding process, thereby suggesting that the tissue cores obtained by 22 gauge needle were quite fragile as compared to 19 gauge needles. And therefore, the specimens which were adequate for pathological interpretation were much better with 19 gauge needles as compared to 22 gauge needles. Then once we have learned that 19 gauge needle is better than 22 gauge needle in obtaining the tissue sample, as well as the safety aspects are comparable, the next step is to compare whether the 19 gauge FNB needle gives us a better sample as compared to a 19 gauge FNA needle. And this was again a prospective study comparing acquire needle with an expect FNA needle. And this study proved that the core needle had increased performance in all the standard metrics, that is the portal tracts, the length of the specimen, the fragmentation rates in comparison to FNA needles. So hence what we have learned is that a 19 gauge FNB needle is better than a 19 gauge FNA needle. Now we have a number of commercially available FNB needles. We have a ProCore, we have a SharkCore, and we have a Acquire needle. Now, which of the needles should be used? This was a study which has been recently published comparing 108 adult patients undergoing a US guided liver biopsy of left lobe of liver using a fork tip and an Acquire needle. This is simultaneously and sequentially using in a same patient. So this study showed that the Francine needle had a better diagnostic yield, increased number of complete portal tracts, increased mean specimen length, as well as increased intact cores in these patients who underwent an US guided liver biopsy of left lobe in comparison to SharkCore needle. So this study has shown that the fork tip has a less chances of adequate sample as compared to a Francine needle. Now, another important aspect is to use suction, and if to use suction, which suction? Dry or wet suction. This is again a prospective study evaluating an US guided liver biopsy using a 19 gauge core needle using 3 preparations. One is a standard needle directly from the package, which is a dry suction, a needle which is primed with heparin and then flushed with air, which is a dry heparin, and a needle flushed with heparin and having a wet suction attached, which is a wet suction. So this study showed that the wet suction needle gave us a longer aggregate specimen length, the length of the longest piece, more portal triads, and less fragmentation as compared to dry suction. And importantly, this study also showed that there were no deleterious effects of heparin on tissue cytology, histology, and even on histochemistry. Hence, this study has shown that a wet suction 19 gauge FNB needle probably is going to give us the best specimen for evaluation under histopathology. Then the next question arises, what are the number of passes required to have an adequate amount of liver biopsy? This was a prospective randomized study comparing 1 versus 3 needle actuations for US guided liver biopsy using a 19 gauge Acquire needle. And this study showed that 3 actuations provided more tissue than a single actuation. And this diagnostic yield was much better with 3 actuations as compared to 1 actuation. However, a long specimen which was robust was obtained with a single pass as compared to 3 passes, because 3 passes used to lead to more tissue fragmentation. Now, summarizing how to obtain a best US guided liver biopsy specimen, we should use a 19 gauge core needle, which is a 5 needle biopsy needle. Wet suction is preferred. The suction syringe is turned on once you do an actuation of the needle. And then you should do 3 deliberate to and fro movements with slight fanning, with a slight change in the trajectory of needle with each pass. And one should do a bilobar sampling, which can reduce the sampling error. So currently, by doing these 4 maneuvers, we will be probably achieving a diagnostic yield of more than 95% in patients with diffuse liver diseases. What about complications? The studies have shown that the complication rates with US guided liver biopsy are very less, and this was a pooled analysis of adverse effects of 8 studies and 437 patients, and the frequency of adverse events was just 2.3%, and pooled rate of bleeding was 1.2%, and majority of these bleeding episodes were mild, with only a handful of patients requiring intervention for control of bleeding. So summarizing that, these studies have shown that US guided liver biopsy is safe with very minimal incidence of adverse effects. What about disadvantages? Although it looks to be very fascinating, the cost of needle, the cost of the procedure, and the need for sedation are some of the important limitations of US guided liver biopsy. And moreover, to perform an US guided liver biopsy, you need a trained endocrinologist, the number of whom is much less as compared to a trained radiologist who can perform an US percutaneous guided liver biopsy. Now, this was just a few days back published study comparing US guided random liver biopsy in comparison with transjugular and percutaneous approaches. So if you look at the results of these studies, the adverse events were comparable with 3 approaches of obtaining a liver biopsy. The technical success was 100% with all the 3 approaches, and the diagnostic accuracy was again comparable across the 3 groups. And the only differences were complete portal tracts and specimen length were better with EUS guided liver biopsy as compared to percutaneous and transjugular liver biopsy. So in summary, it seems that EUS guided liver biopsy is safe, and possibly use of a real-time Doppler and real-time EUS guidance decreases the risk of complications. And these studies have shown that it has got a lower or a comparable complication rates as compared to percutaneous and transjugular liver biopsies. It seems to be clinically effective also because you are reducing the sampling error by fanning and ability to sample both lobes of liver in real-time guidance. There is a possibility of simultaneous evaluation of pancreas, gallbladder, common bile duct, and other structures which can be helpful in liver diseases like primary sclerosing cholangitis. You can do a concurrent esophagogastroduodenoscopy to evaluate for upper digestive disorders and evaluate for varices. And now we have learned that it has got adequate as well as superior specimens as compared to percutaneous and transjugular liver biopsy. So it seems to be a very fascinating idea of doing an EUS guided liver biopsy. You can evaluate for varices. You can look for common bile duct and other disorders. As here you can see in a patient with PSC, the bile duct is thickened. You can do a elastography to measure the liver stiffness. You can do the portal pressure measurements by an EUS guided puncture of the portal vein. And then in the end, you can even perform a EUS guided liver biopsy. So it seems that it's a single stop procedure for complete evaluation of patients with diffuse liver diseases. So to conclude, the inherent advantages of EUS guided liver biopsy seems to be clear. From patient's perspective, it seems to be safe and largely painless. From a technical perspective, it allows for sampling of wider area of liver, and importantly, the liver biopsy is not hindered by presence of morbid obesity. The diagnostic yield is now proven to be well beyond conventional standards, and the information obtained by EUS guided liver biopsy is further bolstered by same session mucosal inspection for signs of portal hypertension and direct measurement of portal pressure gradient. So ladies and gentlemen, with ongoing refinement in needle type and suction techniques, further improvements in the sample quality of EUS guided liver biopsy are only a matter of time. And I think EUS guided liver biopsy is going to be reaching its prime time shortly in evaluation of patients with diffuse liver diseases. Thank you so much for your patient hearing.
Thank you, Dr. Rana, for such a wonderful talk. I think you covered almost all the aspects of the liver biopsy in a very wonderful manner. Before I ask some question, there are some questions from the audience. One that how deep the biopsy needle has to be moved within the liver.
Yeah, it's a good question. You know, there is no specific measurement. You just want a liver biopsy which is more than 2 centimeters long. So roughly a puncture of about 3 centimeters of liver should be good enough to get a good tissue.
Right. Basically, the to and fro movement all should be within the liver. That is what is the requirement, I believe.
Yeah.
And the second question is, what is the practical indication of EUS liver biopsy percutaneous?
तो देखो
I couldn't hear you because of the now you can repeat.
Practical indication of EUS liver biopsy over percutaneous.
Yeah, I think it's a very, very important question, especially in our context, you know, because in our country, the percutaneous liver biopsy is much cheaper and it is widely practiced. So what I think is, even at our center, EUS guided liver biopsy still is being performed very infrequently. Most of the hepatologists are very convenient doing a percutaneous liver biopsy. So I think with the availability of EUS guided portal pressure measurements, then probably we'll be shifting towards EUS guided liver biopsy. But currently, I think patients who are morbidly obese or who have, say, mild ascites, we prefer doing an EUS guided liver biopsy over a percutaneous liver biopsy. In all other situations, still percutaneous liver biopsy is being commonly performed.
So can I comment one thing?
Yeah, sir. Go ahead, Dr. Rajesh.
So one thing is when you do an EUS guided liver biopsy, expelling the material, it is important you should not use stylet, otherwise it is going to break. It's always better you should flush so the entire core of the tissue will come. That is the important trick. My only worry started in EUS guided liver biopsy is in percutaneous, you can seal the tract, but in EUS, we have no definite method. If the bleeding happen, how we can control it? In percutaneous method, they seal the tract through which they have gone. But with us, that is the disadvantage. I still not able to find this answer that what should be done to prevent the bleeding when doing the EUS guided liver biopsy. Any tips?
I think those are valid concerns. First, I think fragmentation would probably happen less frequently if you're using a wet suction, and fragmentation was more a concern with a 22 gauge needle. But I think it's a very important point that using a stylet will probably lead on to more fragmentation. So you should use syringe to expel out the specimen. But again, one should not be forcefully expelling out the specimen. It can again lead on to fragmentation. And regarding the tract embolization in US guided, I think US guided liver biopsies seems to be a pretty safe procedure. You are avoiding blood vessels. You are not going through the even small veins, hepatic veins or hepatic arteries. So I guess bleeding would be a less concern with the US guided liver biopsy. I don't know what's the experience of other panelists, but fortunately we haven't encountered a bleed following an US guided liver biopsy.
No. There's one more question from the audience.
I echo you, Dr. Rana. Plus, we also do some portal vein aspirations and interventions. The theoretical risk of bleeding is there, but we've never encountered any. And even if there's bleeding, I mean, if we just leave the needle there for like a minute, the blood will just clot in the tract, and you usually don't need additional interventions. Of course, you can always inject something more like gel foam or glue if something really continues to bleed. But usually,
Dr. Rana, there's one question from the audience.
Yeah, please go ahead, sir.
There's one important concern whenever you're doing a liver biopsy is what is the coagulation profile. So coagulopathy is one of the most important fear when we're doing the liver biopsy. So the question from the audience are that in such situation when there's a coagulopathy, do you think that EUS guided biopsy scores over the other methods? And how does this EUS guided biopsy compare with transjugular biopsy?
I think, sir, in that situation, I won't advocate an EUS guided liver biopsy if there is a significant coagulopathy, because you are still puncturing the gastric wall. So the coagulopathy concern is that if you are puncturing anything other than the liver, then there are chances of bleeding. For a percutaneous, the risk is because you are puncturing skin and subcutaneous tissue. And similarly, for an EUS guided liver biopsy, the concern is puncturing the GI tract wall. So personally, my preference in a patient with coagulopathy would to go ahead with a transjugular liver biopsy, not do an EUS guided liver biopsy. And personally, I don't have any experience of doing an EUS guided liver biopsy in a patient with significant coagulopathy where the thrombin index is less than 80% or difference is more than 4 seconds. But the panelists are there if anyone has any experience with EUS guided liver biopsy in coagulopathy.
Dr. Rajesh, any experience in doing it by patients with the coagulopathy? Dr. Puri?
No, I have not done in coagulopathic patient, no.
Okay. So I think this was an excellent lecture. We conclude now and we move on to the next lecture. The next lecture is on the technique and tricks and tips of how to do a hepaticogastostomy with EUS. And we have none other than Dr. Isayama, who will be giving this lecture. Dr. Isayama, please.
Okay, thank you very much, kind introduction. I'm Dr. Isayama from Tokyo. So firstly, I want to say special thanks to the Professor Sood and Dr. Puri. This photo is my very good memory in Gurgaon. So I want to see you directly soon, not through the screen. Okay, back to my slide. So today's my topic is ES-guided hepaticogastroscopy. So in Japan, the ESBD is covered by insurance, government insurance. So then recently, many Japanese and endoscopists perform ESBD. So then we required guidelines. So then 2018, we published the clinical practice guidelines of ESBD. So now more and more ESBD are performing in Japan. So I will share my technique. Oh, sorry. So this is my equipment for ES. So I am using both Olympus and Fujifilm machine, but recently I performed the ES HGS with Fuji machine because Fuji machine, the large field angulation is very acute, and also elevator function is very good. So then we can puncture a wide area. Then I select Fuji machine. Needle, we use EG-Shot 3 from Olympus. This is very sharp tip and flexible, and a very important thing is keeping straight shape. So because this needle made by Nichino. If the puncture failed, we employed Sonotip by Mediglobe. This is a very sharp tip needle. Guide wires, we use Vigiglide 025. This is a standard wire in Japan. So, but sometimes we require the hard support. At that time, we select a LivoWave guide wire. This is a very hard wire, and this is a basically domestic wire. But now in Korea, this is available. I have a patent of this wire. This here is my algorithm of the interventional ES. Firstly, 90 gauge needle puncture, auto-fired guide wire insertion. Subsequently, Burji dilation of the puncture route. If you have no good Burji dilator or failed with Burji dilation, I recommend you select quarterly dilator. After quarterly dilation, additional balloon dilation required in some procedure. It is according to the final shape. So if you perform the ES-CDS with covered metal stent, no additional balloon dilation required. But ES-HGS, 4 millimeter balloon dilation we perform. And Pracer plastic stent. So I recommend you employ the double guide wire technique. So additional 035 hard wire required. And insertion with a single plastic stent, 4 millimeter balloon dilation, 2 or 3 multiple plastic stent dilation, 6 millimeter balloon dilation. This slide shows the dilators available in Japan. So we have a domestic very good Burji dilator named ES barrier dilator. If we fail to dilate with this, we switch to the quarterly dilator and flex or Japanese domestic fine 025 very thin tip quarterly dilator. Additional balloon dilation. Previously, we used Hurricane balloon dilator from Boston, but recently we used a LEN with a very sharp tip. It is very useful to insert from the puncture route. This slide shows the catheters for multiple guide wire insertion. So Sohendra VA dilator, 10 French, or Cytology brush, and the Haber lamp catheters are available. And in Japan, we have a domestic special catheter uneven. So this catheter accepted both 025 and 035. Then name is uneven. The metal stent, we used modified geoball, only 1 cm kept anchorable in liver side. And many doctors in the world use a flap stent, but this stent is not available in Japan. we placed over 100 cases of the modified GeoBall for the US HGS. So success rate is very high, and also a clinical success is very high, and without severe adverse event. And the median intragastric stent length is 54 millimeter, so very long stent in the stomach. It is to avoid the stent migration into the abdominal cavity. I think this is a very good result. The technical tips for the ESHGS, which is better, B2 or B3? So I recommend you B3 because the B2 has a potential risk to puncture the esophagus and cause mediastinitis. And sometimes it's very difficult to perform the re-intervention because of very close to the EG junction. If you puncture B2, I recommend you more pushing scope toward to the stomach and angled large wheel and also elevator highest up to avoid the esophageal puncture. To avoid the esophageal puncture, other effective tip is clipping at the EG junction. It is beneficial for the under fluoroscopic procedure. And this slide is very important. So perpendicular approach and tangent approach. If you puncture perpendicularly bile duct, we cannot control needle rotation, and sometimes guide wire stacked at the needle tip. And if you encounter the guide wire stacking, so bring back the needle into the liver parenchyma to release the guide wire. But tangent approach is better. So very smooth insertion of the guide wire and also a manipulation. And we can avoid the sharing of the guide wire. So please memorize the name tangent approach. Puncture point. So we use Fujiscope and performing the this procedure. This procedure, so we can puncture the central area of the B3, a very smooth insertion of the guide wire, and also effective to place a larger diameter stent. So then recently we are performing the USHGS as a left side shape, endoscope shape. This is our recent VTL, puncture of the B3 with a high scope up and angulation, elevator up with a 90 gauge needle, EG shot 3. Guide wire manipulation is very smoothly. And also putting back the guide wire very smooth. And insertion of the Auto 5 BG glide and place the guide wire as long as possible. And after the BG dilation, we insert a balloon catheter and 3 points we dilated. Bile duct wall, liver parenchyma, and gastric wall. And the insertion of the GeoBall, we place the uncovered portion in the bile duct and a fully covered portion in the liver parenchyma. And a very important technique is intra-channel deployment. Intra-channel means intra-stomach. Then we push out the stent delivery system and a free deployment. So intra-channel deployment under the fluoroscopy is very, very important. This is a B2 approach. So relatively pushing the scope and the angulation and using the 90 gauge needle, similar technique. And this case is a benign. So CBD stone case and the insertion of the Auto 5, the technique is a not push, don't push. So rotation, rotation, rotation. And finally, we can pass the papilla. So don't push, rotation of the guide wire is very, very important technique to manipulate the guide wire. Now, bougie dilation with the ES dilator. So subsequently, we insert a special catheter named uneven to insert a 035 hard type guide wire. So double guide wire technique. So after insertion of the double guide wire, so scope stabilize. Now we are dilation of the papilla with a balloon catheter, and now puncture to dilation with a 4 mm balloon. So papilla 8 mm, this area 4 mm. So 3 points. And this case, we try to push out the CBD stones by a retrievable balloon catheter along the 035 guide wire. Pushing ability is poor. So then we employ the 035 guide wire insertion. And now I ask to the Japanese company to make a retrievable balloon with tough shaft, so increasing the pushing ability. This case, finally, we insert a double pigtail stent into the CBD. Of course, we insert a double pigtail stent along the 035 guide wire. So tip of the double guide wire, double pigtail stent, easily to bend. Sometimes fail to insert this stent into the bile duct. So then I recommend you the insertion of the plastic stent along the 035 guide wire. And the more important thing is still keeping the 025 guide wire as a safety wire. So this technique is very, very safe, I think. This is our complication case. So stent misplacement, because we deploy the stent, but so we pulling back the scope, don't push the gastric wall, and finally we deploy the stent totally in the abdominal cavity. But luckily we keep the guide wire, then we place the additional metallic stent. So keep the wire if you decide to no further intervention. It is also very important thing. So this slide shows the importance of the intrascope deployment. So one advantage is the avoidance of the intraperitoneal deployment. The other thing is a shortened intraperitoneal portion. So attach the gastric wall and the liver. It is effective to make to mature the fistula easier. So it is a very good tips for performing the USHGS and also other type of the interventional EOS. Recently, we developed this new stent with a spring stopper, very good anchoring nature. So, and now we are performing the evaluation study. So now we are deployment stent, intra-channel deployment, and the push out. So we place 50 cases of the ES-HGS spring stopper, but no migration occurred now. Now we are performing the multi-center evaluation. So maybe very few in near future, you can use this spring stopper stent from Tail Medical Devices from Korea. Okay, if you have no good anchoring stent, so sometimes you encounter the scarce situation. At that time, there are some tips. One is the anchoring stent technique with a 5 French pancreatic stent through the body, through the mesh. Other one is a clip flap by a forward viewing scope. It is a relatively easy procedure. So making the flap with the endoscopic clip. So please memorize these techniques: clip flap and crisscross. If you want to insert a plastic stent, very important thing is the insertion ability. So thread stent is better, but for the migration, so double pigtail stent is better. Spring bank function is favorable. If you have if you don't have a double pigtail stent without a spring bank function, so I recommend use the centering marker and the distal marking because the endoscopic view is very poor. And recently we are marking full distal marking we performing. So it is very important. Sometimes we insert double pigtail stent totally into the liver. This case we kept the guide wire, but the stent now in the liver parenchyma. So firstly, I insert Sohendra dilator to retrieve the stent, but failed. Finally, we insert biopsy forceps, wire-guided biopsy forceps solved by US endoscopy. So we successfully catch the tip of the double pigtail stent, and finally, we successfully adjust the stent position. So this biopsy forceps is very useful. But the more important thing is look, we kept the guide wire. If we fail to retrieve the stent, we will place additional stent, and after the maturation of the fistula, we can insert the spyglass through the created fistula and can retrieve the stent. So very important thing is the double guide wire method. Okay, I will finish my presentation. Thank you very much for your kind attention. Thank you again.
Thank you, Dr. Ishiyama. That was really excellent. Some of the tricks you told, I think it would be very helpful, those tricks.
Okay, thank you.
So I think we can have a few questions if there are any.
Dr. Lamba?
Yeah.
Just to keep on time, one question is okay because we are 5 minutes ahead. So one question we can ask from Dr. Ishiyama.
I think the lecture was so explicit and good that there are hardly any questions from the audience. So I think we can move on.
Question? Can I ask one question?
Yeah, sure.
Oh, Ratut.
Hi, how are you, friend?
Yeah.
Now, as I see that you are a proponent of a hepaticogastrostomy,
okay.
So when is the case, which is the case where you would not do hepaticogastrostomy and you do anterograde hepatic route biliary stenting? Do you do that or you just do hepaticogastrostomy?
So very good question. So most of the malignant structure, I employ the hepaticogastrostomy rather than the antegrade stenting because easy to access to the bile duct from the stomach. Then I love the HGS rather than antegrade stent.
Okay, thank you.
Okay, thank you. Very good question.
Thank you.
So I think, Roy, we can move on to the next.
Yeah.
Okay.
Hi, Vipul. Welcome.
Hi, Roy. How are you? Hi, guys, everyone.
Yeah, I think you can start on. There's no need of introduction, Vipul, Roy, to this. You hug his guardian, but I think you can start on.
Okay. So first of all, Rajesh, a brilliant show, and the entire team at Medanta. Thank you very much. What I'm going to talk about, my favorite topic, EUS-ERCP interface, a case-based perspective, the lessons learned over the last 2 decades. So we all know the complexity of the entire pancreatobiliary anatomy. And if you ask me what are the objectives for today, I would give you a little brief historical background, role of EUS-ERCP in biliary diseases, role of EUS-ERCP in pancreatic disease, and then the overlap of imaging and treatment roles of EUS and ERCP, which you just saw Professor Isayama brilliantly demonstrated in his work. So if you look at the history, we are almost 100 years now in the quest of looking at the bile duct and the pancreatic duct. 1920, that's when it started. So it took almost 100 years for us to really get deep into the biliary and the pancreatic ducts now. And these are some of the earlier evolutionary procedures by the pioneers in that era. And of course, the most important landmark intervention came about in a biliary sphincterotomy in 75 by Professor Kawai and Klassen. And of course, then Professor Nipsohendra in 1978. So this opened the floodgates of endoscopic intervention in biliary pancreatic anatomy. And if you ask me, I can never start or complete my talk without thanking my mentors. Ken, not just because you are here on the screen, but this is my regular slide in every talk. So I'm thankful to you and Nib for what a fantastic time in the history where I was mentored by two greats in respective field. So I'm thankful to my mentors. Coming to role of EUS in pancreatobiliary diseases, we can detect stones, tumors, helminths. We can diagnose etiology of recurrent acute pancreatitis, staging of biliary and pancreatic cancers. Of course, we can have tissue acquisition and the therapeutic aspect of EUS interventions in CPN or pancreatic fluid collection or even biliary drainage and the pancreatic ductal drainage. But that's not I'm going to talk about much. I'm going to talk about the role of EUS and ERCP on decision and outcomes. So first question is ERCP necessary in every patient with an altered LFT or some imaging which is showing some abnormal dilatation of the biliary system or some problem in the pancreatic duct? Well, can EUS alter the approach of therapy? Can EUS also influence the pancreatic endotherapy decision, which duct you will manage? You'll go for accessory duct, you'll go for main pancreatic duct, whether you do both the sphincterotomy, all those details, EUS can map the entire pancreas and give us some idea on that. And of course, it could reduce ERCP-related complication because we have stopped doing injection of contrast, at least in the malignant biliary obstruction for almost so many years now, once we do EUS mapping and just straight stent and out. Does it impact surgical strategy? I'm sure if you have proper staging and any need for new adjuvant treatment prior to a decision making for major surgery or for palliative purpose. So I'm going to just take you through some cases, and this entire presentation is addressed to our young endosonographers, aspiring endoscopists, where all the cases had multiple imaging and no definitive diagnosis was made. And then the question was, what if we had done only an ERCP? So this is the question I'm going to ask. So if you look at the traditional biliary stone disease, now a stone disease like this can be beautifully picked up on EUS. It's just a matter of 2 minutes. I still use radial. Well, I'm old school, but I love doing radial because it's very quick. But the problem is when you have very, very tiny stones, and that is what EUS is good for. And if you look at this anatomy in small duct disease, I mean the duct is not dilated, hardly 3 millimeter, 4 millimeter bile duct, and there is no diagnosis. And that's where you pick up very tiny stones, as you can see with both cases, multiple small stones in the gallbladder. Look at normal bile duct, absolutely normal CBD. And just in front of the ampulla, you see a 3 or 4 millimeter stone sitting in just above the ampulla. Now, this is where EUS scores over almost all imaging. So as far as I'm concerned, no MRCP, common hepatic duct, down ampulla, only EUS for last 22 years. So something which I feel that youngsters, if they pick up, I heard some speaker yesterday about the cost effective of EUS. And I feel if you do not include EUS in your algorithm high up in the diagnostic chain, you're not going to make it cost effective. Secondly, if you have some rare conditions like this, say for instance, this patient, a 14-year-old female, a young girl, multiple pain episodes, only one GGT abnormality, and you can see here, there's something taking a somersault in the bile duct. And this was a live fasciola gigantica in the bile duct, which was missed for almost 4 years. So whenever we have a biliary pain or suspected some kind of a problem, especially one report of altered GGTP, I think we should straight away consider good quality EUS and immediate intervention. And this girl immediately got solved of her problem. Fortunately, the surgeon, even ERCP could not show me a proper, in a good fluoroscopy machine, I could not see it. So this is the pathology which was sitting inside. Coming to children, and now patients were referred to me for suspected sludge on MRCP and in a choledochal cyst, and patient had mild problems. But the actual problem was patient had stone in the pancreatic duct, and that was causing the pain in this child. And there was an abnormal communication with the choledochal cyst with the pancreatic duct, and that was the reason for the patient's pain. Of course, had the surgeon operated the choledochal cyst without clearing the pancreatic stone, the symptom would have persisted, and that was probably detrimental for the child, especially such a young child. Coming to an 18-month-old baby. Now, I want all of you to pay attention here that in India, we have a problem because there are some hygiene issues. And in an 18-month-old baby, I was referred to with severe cholangitic symptoms and severe pain with elevated amylase lipase. Everybody thought that there is something in the bile duct. They could see something on CT that everything is filled. So on even an 18-month-old baby, you can do a very good quality EUS with a radial. It is smooth to do it. The youngest baby I have done with adult radial is about 7-month-old baby, and it is possible to do it comfortably after a certain level of experience. So I could see multiple roundworms in the bile duct. But what is important for us to see now here as I come in the pancreas, that there was a Escherichia sitting right in the pancreatic duct, which was completely missed on imaging studies. Now, these are the things which you need to understand. Look at this. This is the pancreatic duct, and the Escherichia is sitting right inside the pancreatic duct with the gut. I can see the bowel of the Escherichia through the EUS. And this is the beauty of endoscopic ultrasound, where you can pick up this kind of pathology and then address this in a very specific way. So I'm not going to show the intervention part. Yesterday, I think some colleagues mentioned about the lower bile duct. I fully agree that if you have a lower bile duct pathology not very clear on CT, MR, I think the best way to do is EUS. And we found out a fleshy lesion in an 88-year-old gentleman. It's like a papilloma just in front of the ampulla. That's the pancreatic duct, that's the CVD. And what we actually did was we did endoscopic resection of this intraductal papillary lesion. Because he was unfit for surgery, we stented the pancreatic duct, and then we took out this papillomatous lesion, which showed mild dysplasia. Subsequently, this patient passed away after 4 years because of some cardiac condition. But as far as the biliary part was concerned, I think he was sorted. So a combination of EUS and ERCP in biliary would help you to make accurate decisions regarding pathology. Now, I'm sure Rajesh has presented extensively on lymph nodes, and this is my experience also. The patient with mild LFT abnormality, jaundice, and if you have lymph nodes seen on CT or ultrasound, don't jump on ERCP, go for EUS. We saw multiple stones compressing the bile duct in the hilar region. All we did was EUS guided biopsy. It turned out to be tuberculosis, and then patient went straight with the antitubercular drugs, and that was sorted. So it helps you to make a decision to avoid ERCP in such situation where ERCP is not necessary. So my personal take is that whenever you suspect something unusual, it's better we do a good quality EUS and then take a biopsy and do it. Moving from there to pancreas very quickly because of paucity of time. Somebody said it's a very enigmatic organ, and I fully agree. We all agree that the diseases are detected late and even more difficult to treat. So if you ask me, what is my wish list? My wish list for EUS is this. Someday, somebody will come with a chromo ultrasound and have an entire black and white image giving me something like this on endoscopic ultrasound. That's my wish list. So Rajesh, you should work on this, and you can probably come with a technology with software and artificial intelligence. Coming to the role of EUS in pancreatic disease, I think this is the series of, or all the indications which I usually do in my practice or for the last 2 decades. I'm going to skip for the cause of the paucity, but usually we stage pancreatic mass. I'm not going to talk of pancreatic cancers, but a definitive role. Yesterday I heard others, resectable, we don't do the US, unresectable, you need FNA. I feel resectable or unresectable, you still need a US to pick up small lymph nodes, minimal ascites, and small liver mets, which are missed on a PET CT scan. I'm not going to get into the debate, but I want to definitely get here in a chronic pancreatitis case. Patient, 28-year-old young man, referred to me for endotherapy. And what if you have done just ERCP or endotherapy, because this patient had mild obstructive jaundice. So whenever a patient has mild jaundice, you straight away suspect something fishy apart from a pancreatic head mass or a stone impinging on the bile duct. And we found an irregular mass here in the head of the pancreas, and that was a cancer sitting in the setting of chronic pancreatitis. So we had seen in our practice, patient was stented for the pancreatic duct, and then after 6 months, patient lands up with a liver metastasis. So I think EUS becomes extremely important before decision-making, even in an established chronic pancreatitis. Coming to pseudo masses like this, again, Rajesh has published on this, and then he made India very proud. This is one such case of 18-year-old patient. This had a mass, and he was advised surgery by some leading 3 surgeons in Mumbai. And then we did endoscopic ultrasound guided biopsy. It turned out to be primary tuberculosis of pancreas. And this young 18-year-old boy could avoid any major surgical intervention. So this is the impact. So we did brushing also for this patient. You will not believe, and did ERCP, and the brushing was inconclusive. And this is something which our ERCP enthusiasts should understand, that if you do just an ERCP with brushing, you are going to miss some diagnosis, and therefore a combination of EUS with tissue acquisition is important. Coming to recurrent acute pancreatitis, a lot of debate has happened, but I have my own ideas about it. But I want to share with you that what has happened in the last 20 years, that we have stopped, at least I have stopped injecting contrast in the pancreatic duct. And this is the reason. This patient had a gallstone 6 months back on ultrasound, came with a pancreatitis. See how beautifully you can see the bile duct. You see the pancreatic duct, the stone actually went into the ampulla and then reflux in the pancreatic duct. Now this kind of specific information, very specific. So I don't need to even deal with the bile duct. Gallbladder is empty. You can see, guys, gallbladder is completely empty. I don't need to touch that area. I went inside. This is not chronic pancreatitis, believe me. This is a solitary gallstone refluxed back into the pancreatic duct. And this is something which you need to understand. So what I do, I'll just share with you our technique. We do not inject contrast after a proper EUS mapping of pancreas. I don't need it. I'll just go pancreatic sphincterotomy, stone extraction, and out. So this is something which we all need to understand if you effectively diagnose a problem. So everybody's talking about interventional EUS. Come on, guys. We have not even explored the full dimension of a diagnostic EUS. So let's do that first. And I think, Rajesh, we need to emphasize this to our young colleagues who are aspirant. Everybody wants to stick a needle and do some therapy, but diagnose like this, and you can have a very specific intervention. Again, a young girl of 20, recurrent acute pancreatitis. These are rare cases, of course, in the Western world, but in India, we do see such cases. Again, multiple MRCP, CT, everything missed it because this is not chronic pancreatitis. This is recurrent acute pancreatitis, undilated ductal system, and you can see a live roundworm in the pancreatic duct. You can see the gut here, the stent-like structure in the pancreatic duct. Immediately, we intervene, and you have to understand there are no parenchymal changes. You have to be so careful here, otherwise you will blow this pancreas of this young girl, 20-year-old female, and we all know that how pancreas can behave. So we managed to go in and take it out with that. Of course, we injected just to demonstrate the roundworm, and then we managed to take this helminth out with the help of balloon, but it was alive. So another myth was broken, that roundworms do not survive in pancreatic duct. No, they survive in pancreatic duct with the pancreatic juice and probably grow even fatter in the pancreatic duct. So this is something which we all need to understand. Now, I'm sure all of we have understand this patient came to me with anemia. Interventional radiologist, no aneurysm, CT negative for pseudoaneurysm. Patient had hemosuccus pancreaticus. On EUS, I tried on color Doppler to see any abnormal vascular structure. Once I saw multiple large soft stones in the pancreatic duct, no vascular activity on EUS color Doppler, I was comfortable, I can intervene here. So in a bleeding ampulla, as you can see here, we're spitting blood on my face while we were entering it. Now, I want to highlight some of the facts here. If you look at young patients in India, we are looking at soft stones. If you are looking at alcoholic chronic pancreatitis, we are looking at hard stones. So in my experience, if you have a patient young with no history of alcohol, very likely you're going to come across with soft stones in the pancreatic duct, at least in India, because of so many problems, genetic mutations, and we don't know many reasons. But this is what came out. You see what came out. And this is how endoscopic ultrasound allowed me to map the cause of this patient's pancreatic pain and anemia. And we were able to handle this kind of soft, large stones. Young babies, yes, you can have intervention in 1.5-year-old child. Rajesh, you'll have to give me 2 minutes because everybody took 5 minutes. So I'm sorry, but you'll have to bear with me. But young children, 20-month baby with recurrent acute pancreatitis, there was a small fluid collection in the head area, and we were able to map the pancreas in detail for this child also. And therefore, we managed to treat this child effectively with the help of endoscopic intervention, and that child did very well. Last, not but the least, a case like this, recurrent pancreatitis, undilated duct, what would we do? And this is what we are going to do. See, I want all of you to pay attention, those who are US enthusiasts. Why diagnostic US is important? I'll tell you why. This is an inflammatory head mass, inflammation. In the acute pancreatitis, I'm intervening with EUS. This patient had recurrent pancreatitis. Every 10 days, he gets a pain, every 10 days. And then everybody told nothing can be done. You can see the CBD. You can see the pancreatic duct here in the ampulla. And then I see a small stone, 3-millimeter stone in the minor papilla. This is the minor papilla. A 3-millimeter stone, which will not be picked up by any imaging you know currently on the planet. And therefore, my personal take is even in undilated duct, if you have to intervene with EUS first to map the pancreas, if you're good at it, you must do it. And once more and more people start doing it, I'm thinking young people like Rajesh can definitely do some prospective study on this. So I did a major and minor papilla sphincterotomy. This is a minor papilla pre-cut I'm doing, and see what pops out of the minor papilla. A small 3-millimeter stone. This patient would have never settled without any intervention. So even undilated ductal systems, you should consider an EUS. Coming to the crossover. Now, EUS guided biliary drainage, we heard a brilliant talk by Isayama, but I was very fortunate to get the ball rolling for this part of the world in 2001. So it took almost 20 years, guys, for us to, from 2000 to 2021 now, to establish a technique which is still not crystallized because we don't have accessory. I'm sure Ken would agree that hot Axios has made a big difference, but still we need better platforms to support other interventions in this field. So ladies and gentlemen, to conclude, I would never conclude, but my observation that EUS will give you a very high negative and positive predictive value in terms of any obstruction in the biliary tract. It allows you to rule out tumors, and it allows you to stage the disease at the same time. In terms of pancreas, I feel that it allows a proper mapping. Though my wish list is a colorful pancreatic image on EUS, but I think you include EUS in your mapping, in the mapping before any treatment, be it surgical treatment or even an endotherapy. I think EUS will make a major impact in decision-making for patient outcome. I thank you all for your patient hearing. Thank you.
Thank you, Dr. Vipul. Thank you for the excellent presentation. And because of the shortage of the time, I request, because
no, you can give me 2 minutes.
Yeah, we are 5 minutes late and the next session is awaiting. So I thank you, Dr. Vipul, for giving this excellent talk.